Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find all of our previous episodes on Apple Podcast, Spotify, and on your favorite podcast app. Today, we're diving into the complexities of psoriatic arthritis with the one and only Dr. Philip Mease. We'll explore how to diagnose psoriatic arthritis in patients with psoriasis, as well as the latest treatment options and the future of precision medicine in this field. Dr. Mease will share his insights on evaluating joint pain, the role of enthesitis and axial involvement, and how to differentiate between inflammatory and non-inflammatory causes of joint pain in people with psoriasis. You'll hear deep insights about psoriatic arthritis from a master physician. Dr. Philip Mease is Director of Rheumatology Research at Providence Swedish Health and clinical professor at the University of Washington School of Medicine in Seattle. His clinical practice is based at Seattle Rheumatology Associates, a Providence affiliate. Dr. Mease earned his undergraduate and medical degrees at Stanford University and then completed residency in internal medicine and fellowship in rheumatology at the University of Washington School of Medicine. He was there right at the beginning of the biologic revolution and has been a leader in psoriatic arthritis for over 2 decades. He is the most published expert in psoriatic arthritis worldwide. He's won multiple awards for his work on his research in psoriatic arthritis and for his teaching. Dr. Mease is past president and founding organizer of the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, otherwise known as GRAPPA, and he's the current treasurer and education committee chair of GRAPPA. Please enjoy this enlightening conversation with Dr. Philip Mease. Philip, welcome to the show.
Thank you, Jonathan, for having me.
So, one of the common scenarios that we see in rheumatology clinic is a patient with psoriasis that is followed by a dermatologist. And the patient complains to their dermatologist about joint pain. I think many times the dermatologist thinks, oh, it must be psoriatic arthritis, and then they refer these patients to the rheumatologist. How do you think about evaluating patients with psoriasis and joint pain and trying to figure out whether or not they have psoriatic arthritis?
Jonathan, that's a great question because it is true that oftentimes these days dermatologists kind of assume that if the person complains of pain or some kind of problem that of the musculoskeletal nature, they have psoriatic arthritis. They've had psoriasis for a number of years, and they know that 30% of patients with psoriasis will ultimately develop evidence of psoriatic arthritis. We see patients and try to sort out what different musculoskeletal issues are going on here. And are there not only one or two, but even more? Because a person can have simultaneously psoriatic arthritis, osteoarthritis, fibromyalgia, and sorting those is part of the art of rheumatology. So we, of course, are looking at things like age, the duration of symptoms, the descriptors that are used. Does the patient clearly identify that they've had swelling? Do they bring in an iPhone photograph showing a dactylitic digit, meaning the whole digit is swollen, or individual joints like PIP or MCP joints might be swollen and visible on camera? So that's always helpful in sorting through, does the patient have an inflammatory arthritis or not? Sometimes I will start asking about symptoms consistent with enthesitis, and then the patient will remember, oh yeah, I had a problematic, persistent Achilles tendon problem or plantar fascia problem last year, or I had this persistent pain in my chest area, which I went into the ER for, and it wasn't a heart attack or pulmonary embolus, but instead it was an enthesitis of their rib cage. And sometimes inflammation where tendons or ligaments insert can precede the actual arthritis part of it. And then the other big area is the spine. So does the person have back pain? And are there characteristics of axial psoriatic arthritis? In distinguishing from degenerative arthritis, there's some key questions. Morning stiffness. How long does it take for the person to get up and about? Do they feel like the Tin Man on The Wizard of Oz first thing in the morning and need Judy to come along with her oil can to get going? That's a strong clue for an inflammatory arthritis condition. Does the pain get worse over the course of the day? A little bit more consistent with osteoarthritis. Are they aching and painful all over and have dreadful fatigue and can't sleep well? That has a little bit more characteristic for concomitant fibromyalgia. So we try to sort these and determine what is the most important set of issues for the patient. And if it appears to be more inflammatory in nature, then we'll take an additional step to evaluate things like laboratory values for CRP or SED rate. We might get some imaging, plain X-ray, or even better, ultrasound or MRI to better understand whether there's an inflammatory arthritis that's present. And then feedback to the dermatologist. Every time you see such a patient, it's an educational opportunity to advance the understanding of the referring dermatologist about what are the key features of either generalized psoriatic arthritis or components of it, such as axial psoriatic arthritis.
Yeah, such important comments. I often struggle with the enthesitis part of it because, Achilles tendinopathy is like incredibly common. I even had it last year for a long time after an injury. And some patients are tender at the patellar tendons, and I'm like, I don't know what to do with that. Also, the chest pain. Just last week, I saw a patient that's had a 1-year history of what's been diagnosed as costochondritis or chest wall pain. And trying to sort out whether those patients have inflammatory disease or not, I found it to be very difficult. I don't know if you have any suggestions for me about how to approach patients with enthesitis and trying to determine inflammatory versus not.
So you've already hit on one important part, and that is that you had a trauma prior to the onset of your Achilles tendon problem. Oftentimes, patients with inflammatory enthesitis will not be able to describe a specific incident, like going hiking with too heavy a backpack or something like that, as the etiology of their Achilles or plantar fascia or patellar enthesitis. So they might be spontaneous. The other is persistence. So instead of being a matter of weeks and reasonably respondent to anti-inflammatory medicines, a inflammatory enthesitis will linger and go on for a lot longer. But then it becomes harder, and distinguishing from traumatic or fibromyalgic enthesopathy can become difficult, and that's where use of ultrasound, I'll be quite frank, is very helpful for us and it can be done pretty easily and quickly. Just pull your portable ultrasound machine into the room and put on a little gel and look for evidence of power Doppler light up or grayscale signal to give us a clue that it's actually an immunologic enthesopathy.
Fantastic. And any tips about the chest wall? Does that require an MRI?
No. MRI, in my experience, isn't going to be helpful, nor do we use ultrasound in that situation. Quite honestly, we use a diagnostic Medrol dose pack. And if the chest pain just melts away, I have a stronger idea that this could be a inflammatory enthesopathy in the chest as opposed to a cracked rib or a mechanical type costochondral problem.
Super interesting. I'm going to have to try that when I see that patient again. Fair enough. So let's say you make the diagnosis of psoriatic arthritis because the patient has a power Doppler signal on their Achilles or they have dactylitis. Among the many treatments that are now approved for psoriatic arthritis, how do you think about figuring out which treatment works best for that particular patient?
It's not easy these days because we do have quite a number of choices. We have different mechanisms of action that have been approved for treatment of psoriatic arthritis. We have a variety of methods for administration, including oral pills, subcutaneous injections, and intravenous infusions. We have different insurances in front of us that may guide us, using a kind word, toward a particular treatment or another. And so all of those things come into play, as well as the potential efficacy and safety. I'm a great fan of the GRAPPA treatment recommendation approach, which is in the GRAPPA group, which stands for Group for Research and Assessment of Psoriasis and Psoriatic Arthritis. It's a big international group that's been around now for 20 years. We started it in 2003, and it's now has over 1,000 members that are both rheumatologists and dermatologists. And we do all kinds of research and education. But one thing is we periodically update treatment recommendations. And our approach is to look at each key clinical domain: peripheral arthritis, enthesitis, dactylitis, spondylitis, skin disease, nail disease, whether the person has concomitant ulcerative colitis or Crohn's disease or concomitant uveitis. All of these things go into the mix in addition to safety factors as we're thinking about which medicines to bring up for the patient to consider their options. And many of the medicines that are currently approved can work well for each of those clinical domains that I've just mentioned. And therefore, we don't necessarily try to put one in front of the other, but instead introduce several of them to patients and describe safety and efficacy, and then get the patient to help us with their decision. And oftentimes, we'll go through this education. I'll give them some reading material, and they'll go home. They'll have a conversation with their family. They may have a conversation with their referring dermatologist, and then come back and quick virtual visit, and we settle on a medicine that we then ask our prior authorization staff person to work with to see if that can be approved for the patient.
Yeah, I think the GRAPPA guidelines that you mentioned, I just saw them, as I was reading them for this episode. Incredibly helpful. And we'll put them up on the ACR On Air website linked to this episode so that, our listeners can access it fairly quickly. One of the struggles with the guidelines is, which I've had, is, somebody has a dactylitic toe and, you feel like, well, it's just one joint, or one digit. Let's do some methotrexate or something mild. But it sounds like for dactylitis, a TNF inhibitor is more effective than something like methotrexate. Is that your typical go-to when you have somebody with dactylitis?
So one of the things that you're commenting on is that there is such a thing as oligoarticular psoriatic arthritis, meaning in the first phase of the disease, it's very common for the person to just have 1, 2, 3, maybe 4 at most tender end or swollen joints, or they may present with monoenthesopathy, such as an Achilles tendon insertion, or monodactylitis that you're just describing, although dactylitis represents arthritis and tenosynovitis, et cetera, in that digit. I tend not to focus on, is it mono or oligo versus polyarticular, for example, in making a decision, because even if the patient has a single dactylitic digit, if they happen to be a violinist for the New York Philharmonic, dactylitic digit is going to have a huge impact on their ability to perform. And similarly with other work situations, that patient with limited Achilles enthesopathy, dramatic story of one of my long-term patients who was doing her postdoc back in Boston, and she described to me that when she was on a TNF inhibitor for after she had developed psoriatic arthritis, it largely controlled her joint and skin disease, but she had one Achilles tendon that was really persistently problematic. She had to wear an orthopedic boot and described to me coming out of the subway stop and having to call a taxi just to get to her lab at MIT. And so it really depends not so much on whether it's a single or just a couple of digits or joints, but the impact on the patient. You mentioned TNF versus methotrexate. We do have a study known as the SEAM trial, which showed that TNF inhibitors were more effective than methotrexate when compared head-to-head. That's not too much of a surprise. But nowadays, we have multiple medicines that can be used first line. So in the head-to-head trial between a TNF inhibitor and an IL-17 inhibitor, known as the SPIRIT head-to-head trial, the IL-17 inhibitor was equally efficacious as the TNF inhibitor and musculoskeletal areas, and the IL-17 inhibitor was more effective in the skin. And we're now beginning to learn that interleukin-23 inhibitors can be used first line very effectively, and oftentimes dermatologists will reach for IL-23 inhibitors for treatment of psoriasis these days because of their very good safety profile. And in some patients, that will effectively manage their musculoskeletal symptoms as well. Now, the other thing that you mentioned was, okay, this patient has a single dactylitic digit, but how about the possibility that if we started stooping and using the ultrasound probe in different areas, or in a future time when we're just shuttling a person through a whole body MRI to look for various places of inflammation, it's very possible, if not probable, that that person will have evidence of inflammation that's not yet symptomatic in other areas, in the spine, in other joints, that may then over time become more symptomatic. So even though they look fairly limited in their initial presentation, you'll be surprised at how much actual inflammatory sites are present in that person.
Very good points. And when thinking about which medication to choose for a specific patient, do you have any idea why some patients may respond better to some medications than others? Is there anything that can help us predict which medicine would help, a particular patient the most?
Great question, Jonathan. And I would say that we're entering an era where we've got multiple groups looking for biomarkers that can help steer us with the question that you ask. There are immunophenotypes that we can understand will respond better to, say, an IL-17 inhibitor as first drug to choose out of the chute, whereas others may respond well to a TNF inhibitor or an IL-23 inhibitor. It really is going to, I think, revolutionize our care when we can get into a better era of precision medicine and be able, instead of just throwing a dart against the wall at which drug to choose first arbitrarily, or worse, to have insurance steer us toward use, say, of a biosimilar adalimumab as the first choice simply because of economics. It will be good not only to get to which monotherapy we might be choosing, but which dual therapy we might be using. During the recent study called the Vega trial in ulcerative colitis, the Janssen folks who have guselkumab and golimumab, a IL-23 and TNF inhibitor, found that the combination of the two drugs in ulcerative colitis was synergistically more effective in controlling the disease than either drug monotherapy-wise. And so we may come to a place where we're closer to oncologists. Oncologists aren't going to creep up on a cancer and with a single drug and get partial effectiveness and then add a second drug or switch to a second drug to get further partial effectiveness. They want to clobber that cancer from the beginning. And so I think that we're going to look back on our current era in the future and say, whoa, was that primitive approach? We've got much better guidance with a variety of biomarkers that tell us what immunophenotype will respond to which treatments. And we will learn that treating early before the disease has had an opportunity to destroy joints or do other long-term damage than that aggressive treatment at the beginning and then backing off to have perhaps a safer ongoing treatment. Or we'll get into the era of cell therapy for psoriatic arthritis, similar to what we're now beginning to experiment with CAR T cell therapy in lupus, where we have at least very, very, very long-term remissions going on.
Super interesting. And we actually recently had a CAR T cell episode that I recommend that folks tune in if they're interested on that whole field about how CAR T can affect, are the treatments for people with rheumatic diseases. I love the idea about combination therapy. And instead of doing a step up approach, which is what we've been doing, sort of a step down, you try to get remission first line and then see if you could continue that as you take away medications. What do you think about the use of methotrexate in combination with TNF inhibitors in people with psoriatic arthritis? I feel like in rheumatoid arthritis, we try to do that all the time because we know that it seems to be synergistic and gets people more likely to be into remission. But what about in psoriatic arthritis or the spondyloarthritis? Does it have the same value of adding methotrexate to the other biologics, or do you typically just do, biologic monotherapies?
So you've opened a box to several different topics to bring out. So one of them is that in general, we do find ourselves not using methotrexate as much in psoriatic arthritis, partly because of safety. Patients with psoriatic arthritis tend to be more on the obese side. It's a genetic proclivity that they have. What goes along with obesity? Fatty liver. What goes along with fatty liver? Elevated transaminases. And if you add methotrexate to the mix, you can have more liver injury. So we're a little bit more cautious about use of methotrexate for this reason, not to mention the issues of nausea and so on that patients don't really appreciate. But we're also discovering through clinical trial data that we may not need to use methotrexate in the background with certain mechanisms of action. And I'm going to turn back to the trial I mentioned earlier, this SPIRIT head-to-head trial, to give us some lessons. In that trial, we compared ixekizumab to adalimumab. The patients could be on background methotrexate in that trial or not. It depended on what their managing physicians had them on. And what we learned is that the patients with ixekizumab had similar degrees of response, whether or not they were on background methotrexate. So the monotherapy ICSI patients were compared with the combination between ICSI and methotrexate. And then the same was done with the adalimumab arm of the study. And what we found was that, especially tracking patients out to 52 weeks, but also picked up at 24 weeks, was that, as I mentioned, the ixekizumab arm didn't seem to matter whether methotrexate was there in the background or not. Both mono and combination did well. But with adalimumab, it turned out that the adalimumab with methotrexate proportion of patients did better than the patients who were on adalimumab monotherapy. There was a discernible numeric difference between those two groups. So with adalimumab, we sometimes will tumble to use of background methotrexate, who knows, reducing anti-drug antibodies against adalimumab or other factors that make it so that there might be a little bit better effect if you use it with methotrexate. And certainly in practice, we would say the same for infliximab, where we tend to see more anti-drug antibody development if you don't use methotrexate in the background. But we've learned over time in multiple studies now where in some arm of the study, the patients are on background methotrexate with their IL-17 inhibitor, their IL-23 inhibitor, their JAK inhibitor, and then it turns out that it really doesn't make much difference. So I think that's led to, at least in our practice, much greater non-use of methotrexate in the background, and we don't think that we pay a penalty for that. We get good efficacy, and we don't tend to see anti-drug antibody development with some of the newer mechanisms that we're using, especially IL-17 and IL-23 inhibitors.
Fantastic. And have you noticed a difference between how males and females respond to medications for psoriatic arthritis?
That's a very hot topic, Jonathan. And I've had the opportunity to work along with a woman named Leahy Eder, who is a professor of rheumatology at the University of Toronto. This has been a special topic of research for her. And one of the exercises she did was to look at all of the clinical trials that have been done in psoriatic arthritis where there was available disaggregated data, male baseline disease severity, female baseline disease severity, and then tracking over time to see what responses were. And she found that in virtually all trials, there was a greater responsiveness in males, less responsiveness in females, and there was a tendency toward greater baseline disease severity in the female population than in the male population. Keep in mind that when we're using the phrase disease severity, typically that's measured with a combination of objective markers and subjective markers. So objective markers include swollen joint count, CRP. Subjective markers include tender joint count, patient pain, patient global. So generally, especially of the subjective markers, slightly higher levels in females and less improvement of those subjective markers over time. So what might contribute to that? Well, one thing that is fairly clear is that there may be a little bit more fibromyalgia in a female population than a male population, a little bit more of the phenomenon of central pain mechanism, or now it's being called nociplastic pain, and that's going to influence especially the subjective outcome measures. But there are also beginning to be studies that are showing us that there are differences in immunophenotype between males and females, differences in the IL-17-23 axis, in the way the molecular mechanisms behave depending upon sex. And there may be other factors as well, including neurohormonal. Pointing to Leahy Eder again, she's leading a fairly large study known as the SAGE study. That's an exercise from the GRAPPA group. Our center is one of the centers, and I've helped Leahy with the design of the study. And we're enrolling patients with PSA, male and female, who are starting a therapy. So they're starting a biologic or a targeted synthetic DMARD. And then we're tracking them over time, giving them a ton of questionnaires, including gender-related questionnaires. And we're also looking at different pain mechanisms, how much nociplastic pain do they tend to express versus not. And we're looking at a variety of blood tests to better understand neurohormonal and immunophenotypic characteristics that are different. So we hope to have a better understanding about this male-female phenomenon. One little fun side project that has just been approved for, that our center is leading, is to have focus groups with male patients with PSA, female patients with PSA, each focus group led by an academic medical anthropologist that I work with to do qualitative studies, and then looking at the differences in the way men and women describe their disease, describe their response to treatment. And then at the end, what we're planning to do is to feedback the findings to both groups and invite them to come and be in a group together, which I think I'm going to definitely want to be present in those groups. I think it'll be fascinating. We're calling this the Qual Sage study to sort of complement the Sage study, and we'll be doing focus groups in Seattle, Cleveland with Elaine Husney's patients, and Toronto with Alihi Etter's patients.
Super. So it sounds like, in addition to, in the future thinking about like who the patient is, what their immunophenotype is, it seems like sex also plays a role into their experience of the disease and the response to treatment. Amazing. And there's a ton of treatments out there and for psoriatic arthritis, and I still have patients that struggle and continue having active disease despite trying a lot of these medications. How do you think about some of those tough patients, and how do you recommend that we manage them?
This is another hot topic area where in the GRAPPA group, we have a large working group that I'm co-chairing along with Fabian Prof from Germany. And what we're doing is, first of all, coming up with a definition. What is difficult to treat? And is it different from complex to manage? We consider difficult to treat patients who are showing true immunologic refractoriness. They have been on 3 different medications. They've done well for a period of time on each of those medications, but now are breaking through. And they have more evidence of skin disease, more swollen joints, more back pain, maybe an elevated CRP, maybe some ultrasound evidence of inflammation. And that's subtly different, or not so subtly different, from the complex to manage patient who doesn't have those objective signs of inflammation, but does have evidence of fibromyalgia or mechanical problems, concomitant osteoarthritis, obesity, other factors that are hindering ability to get to a state of true remission. And what we're wanting to do then is, once we've defined as a group consensus among healthcare physicians from around the world, keep in mind that some parts of the world may not have as much access to as many medicines as we have access to in the United States. Also, we are polling patients. We've got responses from 600 patients about what it means to have a difficult to treat or persistently flaring disease. And we're getting this same medical anthropologist to help us decode those patient responses. Once we have a codified definition, maybe it'll be similar to what has been codified in rheumatoid arthritis. It will help several different groups. First, clinicians like you that are struggling with, where do I go next? Do I go to just simply a different mechanism if the patient hasn't yet tried another mechanism, if they don't have any contraindication to it, that mechanism, hopefully? Or is this justification to try to get approval for using dual therapy, putting 2 biologics together? And we are doing that quite a bit in our clinic. That's helped by the fact that if we have, say, a dermatologist or gastroenterologist prescribing one medicine and we prescribe another immunomodulatory medicine in rheumatology, then we have slightly better chance of getting that through insurance. The other groups that this definition will be important for are pharmaceutical company clinical development groups that need to design trials of dual therapy, similar to what I described was done with golimumab and guselkumab in ulcerative colitis, and has recently been done in psoriatic arthritis. It's also important for regulatory agencies such as the FDA to appreciate hey, 10 to 30% of the patients that we're seeing each week fall into this category. So this is a big area of unmet need. And so we need the agency to appreciate that, yes, trials of dual therapy may be important in order to address this unmet need. And then finally, I think it's important for payers, insurance companies in the US or country health agencies and abroad to understand that these are very difficult population and they may need dual therapies or intensification of currently available therapies, like going from adalimumab every other week to using it weekly, for example.
Interesting. So similarly to what we talked about at the beginning, that a patient with psoriasis and joint pain may not necessarily have psoriatic arthritis. In a patient with psoriatic arthritis and joint pain, they may not necessarily have active disease, right? And it's what you mentioned, that the art of the rheumatologist to try to sort out, is their knee pain related to osteoarthritis, inflammatory arthritis? Do they have fibromyalgia? And I guess treating those comorbidities are incredibly important in treating the patient, right?
It is important, and also educating the patient about these complexities is important so that the patient now has an understanding that, oh, all of my pain and fatigue may not disappear with use of this single immunomodulatory drug. I've got to be more accepting of the fact that if I've got concomitant osteoarthritis or concomitant fibromyalgia, that it's not only that's hampering my ability to get to a state of being pain-free or fatigue-free, but it's important to address those. And so OA might be managed with an anti-inflammatory or with a knee injection, and fibro might be addressed with use of an SNRI type medication, or bringing in non-pharmacologic approaches, including counseling, physical therapy, conditioning, going swimming, that sort of thing. So I think that it's important for the patient's understanding to appreciate that it can be very complex.
Fantastic. And we've had incredible discussions here in this podcast with like Dr. Howard Schubiner that talks about pain sensitization and fibromyalgia and sort of some novel treatments with that. And certainly we've had physical therapists that help us to understand, how to manage patients with osteoarthritis. So it's a great reminder that not all joint pain in psoriatic arthritis is the psoriatic arthritis, and trying to distinguish what's what and treating everything, right? So it's not just about treating the fibromyalgia or the osteoarthritis or the PSA. It's about treating all of them almost simultaneously to try to help the patients improve and feel better. So we talked a lot about joints, and certainly as rheumatologists, we're sort of the joint experts. But as you sort of hinted, patients with psoriatic arthritis often have extra articular manifestations of their PSA. And so what's our role as rheumatologists in evaluating for some of these complications and in trying to manage them or help with their management along with our other colleagues?
So I use a couple of phrases here that you're asking about. One of them is, it takes a village. So it's very important to be able to have a friendly gastroenterologist or dermatologist or ophthalmologist down the hallway to be able to work closely with in order to manage inflammatory bowel disease that may be concomitant with psoriatic arthritis and is part of the same genetic family. Similarly, the teamwork related to managing skin disease as well as musculoskeletal disease with the dermatologist and the ophthalmologist for the patient who has uveitis. This brings us back to the issue of dual therapy, that sometimes a patient is being treated for IBD effectively with, say, vedolizumab, which has a very focused effect on the gut inflammation, but then they spring forth with psoriatic arthritis as a concomitant illness. in which case we need to pull off the shelf something that will help more systemically and benefit the musculoskeletal domain. Now, it could be that new medicine that we're pulling off the shelf is going to effectively treat the gut as well, but we often bridge where the patient continues veto for a little bit while we institute our therapy that's going to help musculoskeletal symptoms and then wean away one of the other medications. And so I'm frequently on the phone with the nurse practitioner that works with one of the gastroenterologists that I work with closely, or I'm on the phone with the gastroenterologists themselves as we're sort of strategizing how best to approach this. And similarly, we want to bring in the other practitioners into the mix, including psychologists, physical therapists, and so forth.
Fascinating. Yeah, I think, like you mentioned, it takes a village. Just last week, I was discussing bad uveitis in one of my patients with PSA with their ophthalmologist, and we're trying to juggle. I think she's received like intraocular injections of stuff, and we're trying to manage her systemic therapy. So some of these patients can be quite challenging to treat.
The other metaphor that I will sometimes use is that of an orchestra. So I'm a cellist, so this is something that's near and dear to me, but I'll describe there are times when the orchestra is playing fortissimo, all of the sections. So the patient's spondylitis and arthritis and enthesitis and psoriasis are all going at once. And there are other times when individual sections may be playing just briefly. Their arthritis and skin disease are well controlled, but they've got this pesky Achilles enthesitis that's the clarinet section, let's say. And so I like that picture to educate patients so that they can understand that there can be varying degrees of control of these various conditions, including their gut, their eye.
Fascinating. And Philip, I think you were there at the beginning with the biologic therapies in PSA with studies in etanercept, I think in 2000. What do you see coming down the pipeline?
Wow. Well, it's been quite an arc to observe from that early day when I had a whole boatload of psoriatic arthritis patients because I was working closely with a group of dermatologists who were running a psoriasis treatment center where patients came in for light therapy. Mm-hmm. And so I was the sort of de facto rheumatologist for that group. And when I was asked to help study etanercept, which had been developed by a little company called Immunex in Seattle, and find some rheumatoid patients to test etanercept in, I went down to them and I said, could I use your drug to test it in psoriatic arthritis and psoriasis? And they went, sure, we'll give you drug. You create the study. So it was an independent investigator study that we did I guess we recruited 60 patients in 4 months.
Wow.
And it worked. And so
it certainly did. It certainly does still 24 years later.
And so that got published in the Lancet. And from then on, I just got involved in the field. And it has been a rewarding journey. And now that we're learning a lot more about pathogenesis of disease, it's opening up doors to multiple different mechanisms of action, which can be brought to bear. And I would hope in the future, even some of these really deeply remittive cell therapies might be able to be brought to bear in psoriatic arthritis. So it's been incredible to watch this evolution. So we've got multiple medicines coming, and not only new and novel interleukin-17 inhibitors that are very small molecular entities, such as nanobodies that inhibit IL-17A and F. There's one called sonelokimab. There's another small molecular entity that's an IL-17A inhibitor, izokibep, as well as bimekizumab, an IL-17A and F inhibitor that's coming to us in the fall. And then there's a whole new class of drugs, the TYK2 inhibitors, which are kind of a cousin of the JAK family. which have, and maybe a little bit safer, that have ability to treat psoriasis, psoriatic arthritis, and lupus. So I'm very happy about the options that we can offer to our patients and potentially bring them into a state of low disease activity and remission on an ongoing basis, even if we have to cycle from one drug to another. We can, at the moment, really have very effective therapies for them.
Philip, it's been amazing to read a little bit about your career, like you mentioned, starting back in the etanercept days and all the way, you're still publishing 2024 and going forward. So I really admire the dedication that you've had for psoriatic arthritis and your involvement in all of these research studies that, certainly have borne fruit, and patients wouldn't have all those options without you and your colleagues that are doing this work. So I really applaud you and thank you on behalf of clinicians and patients that take these medicines.
Thank you, John. That means a lot to me. I appreciate it.
And thanks again for your time in this episode. I think I've learned a lot. Hopefully other listeners have too. And certainly I look forward to seeing what else is coming down the pipeline for the treatment of PSA. And hopefully we'll get a chance to speak again. And then you can tell us about all the new treatment options that we have for PSA.
Thank you.
Well, there you have it. Everything you ever wanted to know about psoriatic arthritis, but were afraid to ask. Dr. Mease's expertise and dedication to advancing the care for patients with psoriatic arthritis is really inspiring. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this and other episodes at acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep collaborating with other specialists to improve the care of your patients. And of course, stay healthy.